everybody doing today? Freezing? Without the coats? Alright, today we're going to be covering vascular, and I want to start with reviewing some of our flow principles. So go to flow phenomena in Unit 2 under Canvas and modules. And then click on flow summary. Just bring up that PDF. So remember this document that we went over just to review flow. Quickly review this because a lot of these concepts are going to translate over to vascular. Alright, so we first talked about in flow were the mechanisms, and we had four types of flow, but then we had the fifth, which was stagnant or no flow. Our first was laminar or parabolic, and this was called first order motion, and that was constant, and that's the only type of flow we were able to compensate for with our MRI system. And the flow we're talking about is flow that is perpendicular to the slices. So imagine we had our carotid arteries when we say perpendicular to the slices. So we have our right carotid artery, internal, external, and we have our left carotid artery, internal, external. So when we're talking about perpendicular to the slices, our slices are usually set up like this. So here's our field of view, and then our slices look like this going up. So you can see here how we have axial slices that are perpendicular to our blood flow. So that's what we're talking about, how we can compensate for that particular flow. Today we're going to be talking about how sometimes we're going to be imaging slices or blood that is going to be implaned with the slice. And we're mainly describing our circle of Willis, because our circle of Willis has all these twists and turns. It's not as straight as our carotid arteries, so we're not really going to be imaging using a 2D sequence where we're getting slice by slice. We're actually utilizing a whole 3D slab to image that type of blood flow, which it has more twists and turns. We had other types of blood flow like spiral, vortex, turbulent, that we could not compensate for because it was random. We couldn't really predict that type of blood flow. So usually we get a signal void. Remember, when I talk about signal void versus no signal within the vessel, radiologists sometimes differentiate when they're dictating that most of the time they'll usually say signal void to mean that there's a black spot within the vessel. Okay, so it doesn't mean that there's no blood flow flowing, it's just the MRI system couldn't pick it up, so it's a signal void. And then finally we have our stagnant or no flow, which just sits there like almost like urine within the bladder. That gets those excitation pulse and the refocusing pulse, so it actually becomes bright on our image, just like other fluid pathologies on a T2 wave image. Then we talked about the flow phenomena, and the two main flow phenomena that we really spent time on was time of flight and entry slice phenomena. So when we talk about time of flight can be described as if you increase time of flight, what happens is we get a signal loss. So then we had to differentiate our time of flight effects when we were talking about spin echo pulse sequences versus our gradient echo pulse sequences. Our spin echo, we're a little constrained by that 180-degree refocusing pulse, so it usually creates this black blood imaging. That 180-degree refocusing pulse has to happen for that flowing nuclei, has to get excited and refocused for it to actually produce a signal within that vessel. So our time of flight effects depended on three things: our flow velocity, our TE, and our slice thickness. So as our flow velocity got fast, what do you think happened to our time of flight effects? So remember, time of flight, if you increase your time of flight effects, you get a signal loss. So if you have really fast blood flow in a spin echo, what do you think happens to the signal within the vessel? It decreases. Our signal, which increases our time of flight effect. So increase time of flight, which means a loss of signal. Okay? And then our TE. Remember, our TE is timed by our 180-degree refocusing pulse, because 1/2 of TE is tau, which is from the 90 to the 180, and then the other tau is from the 180 to when we're reading the signal. So if we increase our TE, what happens to our time of flight? Signal loss or signal increase? Signal increase? It's going to decrease our signal. So we increase our time of flight effect, but once again, we loss of signal. Because if we space out our TE, that means we're dragging out when that 180-degree refocusing pulse is going to happen. So basically, there's more time to leave the slice before it gets refocused. And then the only one that actually increases our signal is our slice thickness. So if we get a thicker slice, we have a better chance of getting the 90 and the 180 within that thick slice. So if we have a thick slice, we decrease time of flight effect, so we get an increase in signal intensity. All right, so that describes our spin echo in regards to time of flight effect, but then we also described it with gradient echo. And the gradient echo is their major characteristic of that pulse sequence is it does not have that 180-degree refocusing pulse. Remember, the gradients are refocusing the spins, and the gradients are placed basically along the length of the bore of the magnet. So they can happen at any point. So as long as a spin of flowing blood has been excited, it can be refocused. So we get bright blood imaging with gradient echo. This is also sometimes called a flow-sensitive sequence because, once again, we get bright blood. The second major flow phenomena that we described was entry-slice phenomena, and this is basically described by saturation. And remember, saturation, partial saturation is past 90 degrees, full saturation is 180. So we get a reduced entry slice phenomena when we have with more saturation. So whatever creates more saturation, we get a reduce in entry slice phenomena. And remember, entry slice phenomena means that first slice, that flowing blood is really bright because it's fresh compared to our saturated or beaten down stationary tissues. Remember, fresh blood flows coming in has not received any RF pulses compared to all that stationary tissue that's within our field of view that's already received multiple RF pulses. So fresh means unsaturated, beat down means saturated. So dark, stationary tissue, bright, flowing blood. So the factors that affect ESP are anything that really affects saturation. So if we have a really short TR, it creates more saturation because we are hitting it with more excitation pulses. If our flip angle is larger, we're getting more saturation. If we have slice thickness, we actually reduce saturation because we're having less RF pulses within, I'm sorry, if your slice thickness, let's see, your slice thickness is large, we're increasing our saturation. Thick, we increase saturation because we'll get more RF pulses as it travels through a thicker slice. If our flow velocity is fast, we get less saturation because that blood flow is not going to get those repeated RF pulses if it's really fast. It goes right through that slice, so it doesn't get as many RF pulses. And then our major, most significant factor was our flow direction. We had co-current and countercurrent. Remember, countercurrent reduces the amount of saturation because we're going against flow of blood. And then we talked about our third flow phenomena, which we briefly discussed, and that was intravoxel dephasing. We have different tissues at different phase shifts. And if we have, say, a larger voxel, we're going to have different phases with those particular tissues, and that's going to decrease our overall signal. But if we have a smaller voxel, we'll get less intravoxel dephasing. And then we were able to compensate for these three flow phenomena by these parameters. We had a gradient moment nulling, which was a bipolar gradient, so that our stationary tissue and our flowing blood were at the same phase position. Our saturation bands, remember we can put them either inside the field of view or outside the field of view. And then our even echo rephasing. Remember, water and fat are in phase with each other at certain times, and they're out of phase with each other at other times. So that's where, with that gradient echo, usually it's 2.1, then 4.2, 6.3, things like that. Okay. So that's just a quick recap of what we talked about in Chapter 6, so that you kind of have an idea of what we're going to discuss today. All right. So now let's open this PowerPoint. Anybody got any questions about flow? I'm just recapping that. All right, so what we're going to be talking about is vascular today. And what we're really going to be talking about is how MRI can be used to evaluate both the morphology, which is the anatomy of the vessel, and the hemodynamics, which is the flow of the vascular system. So we maximize the signal coming from flowing blood if we're interested in hemodynamics, or sometimes we minimize signal from flowing blood if we're interested in the morphology of the vessel, because we want the vessel to be bright, or the lumen of the vessel to be bright and the blood flow to be dark if we're interested in the morphology. So morphology here, we could say is, what do you think, bright or black blood imaging for morphology? Black. Good. And then for hemodynamics, bright blood. So if we're interested in maximizing blood flow so that it's bright, what should we do to our stationary tissue? Just like with flow, saturate it, beat it down. Yeah. Once again, this is just a reminder that imaging blood flow relies primarily on first order motion. So what is the first order type of blood flow? Laminar. Or
Parabolic.
Laminar or parabolic, which is constant. Remember, you have different velocities. The velocities slow down near the wall because of resistance, friction, but at the center of the vessel, that's where you have the highest velocity, but once again, it's constant. What happens when we come across a stenosis? Remember, we have a stenosis in the vessel. It's not completely closed, but we have a stenosis. What happens?
Vortex.
We get accelerated through it. It goes faster, just like if you were clinched, squeezed a hose and you made it a little tighter, it causes that water to go a little bit faster. But then once you go through that stenosis, we get that vortex blood flow that wraps around. So once again, we get a signal void of that area. And usually the signal void is larger than the actual area of the stenosis. So this can be done with conventional MRI sequences, but what we're going to be talking about here is MRA. MRI, that's really dealing with black blood imaging, but MRA, angiography, we have bright blood imaging, because we're interested in the angiography or the hemodynamics of that particular vessel. So here are the techniques we're going to be talking about. We have spin echo with spatial pre-saturation bands, which will create black blood imaging. We have gradient echo with gradient moment nulling. Remember, gradient moment nulling helps compensate for intravoxel dephasing, so we put all the signal within the vessel so it doesn't streak across our image. We have instances of that where it streaks across within the neck with the carotid arteries, and sometimes in the sagittal knee with that popliteal artery. So gradient moment nulling helps compensate for that. Our third technique is digital subtraction. Have you guys actually subtracted an image doing post-processing? Have you done that? Where you have a pre-contrast and a post-contrast, and you subtract the pre from the post. The GE systems, you actually put it in there where you have a subtraction like formula, but the Siemens system just does it automatically. Time of flight MRA. You have 2D and 3D. 2D, you're really thinking the carotid arteries. 2D, you're able to cover a larger area because we're not so concerned with saturation. 3D, we have to use a smaller area, and that's really concerned with our circle of Willis. So our 2D, we could say imaging areas like carotids. And then 3D, circle of Willis. Our fifth technique is our contrast-enhanced MRA. That's where we're imaging very rapidly. And we want to catch in certain phases. So we want to catch the contrast in the artery, in the veins, and sometimes delayed imaging too. So if you're doing abdomens, usually we start the pulse sequence right as we hit it at that abdominal aorta. We see that blood flow coming down. We start our pulse sequence because we want to see if the tumor within the liver takes up that contrast in the arterial phase, or if it takes up that contrast in the venous phase, or if it starts to filter out in the delayed phase. So the radiologist is able to diagnose what type of tumor depending on when that particular cancer takes up the contrast, or it allows it to flow out of that particular area. And then finally, we'll talk about phase contrast MRA. A lot of times we're doing phase contrast MRA when we're looking at the superior sagittal sinus. So MRV sequences are usually our phase contrast. Anybody done an MRV of the head? Kiara, you're saying yeah? At the main hospital?
Yeah.
It's usually just one sequence. We get a localizer and then we just use it. Usually it's a 3D image of the entire brain, and we see that superior sagittal sinus, which is a venous structure, in profile. It's a really pretty image. So they're looking for any type of thrombosis or blood clot within that venous structure. And you can actually visualize or image blood flows at different velocities. So you can set your VENC, which we'll talk about, for venous blood flow or arterial blood flow. So it's a pretty cool imaging sequence. All right, so the conventional imaging techniques, we basically talked about in flow. So through these first couple of slices, it's kind of review. So if you have any questions, please ask them. If it's something still not hitting home, let me know. So with conventional imaging techniques like MRI, where we're really doing the morphology, so we're looking at the vessels compared to the actual blood flow, we are going to be using imaging options like pre-saturation and gradient moment nulling. SAT pulses will increase signal void, meaning we won't get signal from that particular vessel. So remember, we usually put a SAT pulse above our field of view in our abdomen if we're trying to null out arterial blood flow, because arterial blood flow is coming down from the top. We usually put a SAT pulse below our field of view of the abdomen if we're trying to null out venous blood flow through the inferior vena cava that's coming up. Gradient moment nulling will increase blood flow because it corrects for intravoxel dephasing. So it puts that signal back into that vessel that otherwise would have streaked across our image. So those are just some imaging options to either reduce signal from blood or increase signal from blood in a particular vessel. Once again, conventional MRI is used to evaluate vascular structures, so morphology. So we use different imaging sequences. Sometimes we need to use a spin echo. We could also use a fast spin echo, an inversion recovery, or a gradient echo. So with our spin echo, we have a 90 and a 180, right? So are we going to get dark blood or bright blood on spin echo?
Bright.
That was mixed.
Dark.
Dark blood, it has this 180. So what does that 180 usually restrict? That really fast blood flow, we're not usually able to capture that with that 180. So usually this is going to be dark. All right, next one. Fast spin echo is usually defined as a 90, and then a 180, and then a 180, and then a 180, and then a 180, depending on what your echo train is. So here we have an echo train of 4. So this has multiple 180s. So do you think we're going to have bright or dark?
Bright.
Dark. Dark. So if you see a 180, just think dark. All right. And then inversion, what do we start with, a 90 or 180? 180. So we're starting with a 180. Then usually we have a 90 and then a 180. So 180 inversion recovery pulse, and then a 90 excitation, and then a 180 refocusing. So a spin echo is part of our inversion recovery, but it's just after our 180. So is this dark or bright blood? Dark. All right, and then our gradient echo. What's our excitation pulse? 90 or different?
90. Different.
Different. So it could be 90, but usually it's going to be less than 90. And no 180, because remember, we're refocusing with the gradient. So then what is our
Right.
blood going to be? Right. Okay. So think 180, usually it's too slow of a pulse sequence to actually image blood. Because our blood flows really fast, so the only sequence that is usually able to capture blood is gradient echo, which is why it's called a flow-sensitive pulse sequence. So that's why when we talk about MRA, they're usually always going to be a gradient echo. Everybody got that written down? So this is just describing what I just went over, that spin echo, fast spin echo, and inversion recovery all have that 180-degree refocus point pulse, which restricts timing-wise of imaging fast blood. But our gradient echo is going to get bright blood because our gradients will refocus those flowing spins anywhere under that coil, or basically the length of the aortic magnet. Okay, so we talked about this, black blood imaging, spin echo. This is an image of black blood imaging. So we have here a two-chamber view of the heart. You guys remember your anatomy from the thorax, going back to A&P cross-sectional? Where is the apex of the heart? Here or here? The front, where it comes to a peak, apex. So here you can see how the heart comes to a peak. Somebody actually, for the cross-sectional anatomy, they actually drew a little heart like this and labeled it that way. What's this line right here between the chambers? Septum, but which one?
Intraventricular.
Intraventricular. So we're really looking at the ventricles here, right? So then which chamber is this and this?
Right.
Which one's the right? What's this one?
Right.
Right. And then this one with the thicker myocardium is the left, right? Because we need that thick myocardium to pump it to the rest of the body. We do have one small chamber up here. What is this chamber? Right atrium. Good. What's this big vessel right here?
Aorta.
Which part of the aorta? Descending. Good. What's this little vein right here? Azygos. Good. What is this right here starting to come? Which lobe of the lung is this? Which side, basically? This side.
That's the left.
The left. Okay. So then what's this emerging here? Huh?
Spleen.
So then what is right above the spleen that separates the abdomen from the diaphragm? Yep. Vertebral body, right? Peanut butter and jelly.
What?
So what's attached to
Wait. Back up.
What's attached to the body? PB. That's how I always remember. Is pedicle, peanut butter. Pedicle to the body, peanut butter.
No.
Say that again. I want to learn it that way too.
Just pedicle to body, so peanut butter. That's how I always remember. And then the lamina is attached to the spinous process. I don't have one for that, so.
Oh.
All right, so then pedicle, transverse process, lamina, and spinous process. Is this a T-spine or an L-spine?
T.
T, because we have a rib, right? You have the rib attached to it. You have your costovertebral joint, costotransverse, where it hits the transverse process. What are these muscles back here? The pecs are in the front.
Erector spinae or
Erector spinae muscles. Yeah. Latissimus dorsi here on the side. And then anywhere you have a break in the rib, that's your, what is that? It's the muscle
cartilage or serratus muscle.
No. Costo muscle is the muscle between the ribs. All right. And then what's bright on this image? What do you think? What is all this bright? Is it a T1? Because look, the CSF around the spinal cord is dark, right? And what's bright on a T1? And look at all this fat around the heart too, right? So, a lot of subcutaneous tissue around the heart. So, that could be a reason why we're imaging this particular patient's heart. So just a quick anatomy review there. But you can see here how you're able to see these vessel walls a lot better, right? Because they're higher in signal versus the blood that is dark. So is this morphology or hemodynamics?
Morphology.
Morphology. Good. So intralumen, signal void, lumen, signal increase. So this is just talking about how inversion recovery is once again black blood imaging. And inversion recoveries, they used to be a 180, 90, 180, but this was a very slow pulse sequence. So what they combined our inversion recovery with was a fast spin echo. And now we have a train of 180s after that 90-degree excitation pulse. So you start with inversion pulse, 180, 90, and then a train of 180s. But we still get black blood imaging. But this is just a reminder that our inversion recoveries are typically also a fast spin echo. Sometimes we utilize these inversion recoveries. We do double and triple to really make the blood flow within the heart of those chambers really dark, so that we can see maybe an infarct of our chambers. So which type of slice do you think we have here? I know you guys haven't done much cardiac, but which chamber do you think is this right here?
Isn't that so just the left ventricle?
It's the left ventricle. So this is what we call a short axis view. So we are kind of doing an oblique slice through the ventricles, and we have the left ventricle and the right ventricle here. Remember that right ventricle was more anterior. Here's the front of the patient. That left ventricle was a little bit more posterior. We could really see those chambers well in profile. This is called a short axis view. So what happens in a double IR is we apply an inversion pulse to the entire region that we're going to scan. So that entire field of view, we apply an inversion pulse. And then right before we acquire the information from one particular slice, we apply one more inversion pulse at the slice. So that makes it really dark within the chamber, or within that lumen. And then sometimes they actually do a triple IR for these cardiac cases, and they have these two, and then they apply one other slice-selective inverting pulse to fat. So our fat is also inverted. So all this subcutaneous fat would be dark too. So that just shows you that we're going to be able to really see if there's any type of pathology, myocardial infarct, or any other like cancer or cyst within the wall, we're going to be able to see it that much better because it's going to appear bright. So this is what a double IR looks like versus a triple IR. So you can see here we have blood flow that is dark, and then now we have subcutaneous fat that is dark. So there is pathology on this particular exam. So try and find it.
There was something in the aortic. Not sure.
Okay. What is that? Is it a circle, square? Describe the shape.
That area of signal in there.
Right here?
Yeah.
Right here.
Yeah.
Okay, so we said blood flow would be dark, right? Because we can't capture it. So if there's something within the chamber or within that vessel and it appears bright, so what do you think is going on? Has that blood slowed down in some way? So what is a slowed down
Like a
blob
thrombus.
of blood? Yeah. So it's a blood clot, a thrombosis. So what vessel do we think this is, though? So which chamber of the heart usually is right here? The left what?
Atrium.
Atrium. What flows into the left atrium?
Oh, yes.
Superior.
The what?
Superior and inferior. Yeah.
No, left. That's the right atrium.
All right. Left.
So what flows into? What's the vessel that leads to the left atrium? So you go to the lungs, you come back from the lungs, and you drop it into the left atrium. What is that vessel coming back from the lungs?
Pulmonary artery.
Pulmonary artery. So think about having a blood clot coming from the pulmonary artery. No, it's the pulmonary vein. Because when you're leaving the lungs. Pulmonary vein. So thrombosis in the pulmonary vein. So this is just saying those saturation pulses will fully further null blood flow. You can put them above and below our field of view, depending on if you're trying to saturate arterial versus venous blood flow. So here's just an example of when we utilize that sat pulse outside the field of view, it further saturated out our flowing blood so that we were able to see this pathology in this particular vessel. This is kind of a weird slice here. It's kind of hard to tell, but it looks like this is going to start to be the aorta that will come over to here. But we have a dissection, it looks like, of the tunica intima, which is the innermost layer of the vessel. This is just describing what sat pulses do. When we described that last time, it applies a 90 degree before that flowing blood goes into our field of view. So here's a good image of it. So we put a sat pulse above, and imagine this is our stack of field of view of the abdomen. Our blood flow's coming down through the descending aorta here. So we put that sat pulse above to flip the spins 90, so that once they go into the stack, they get flipped again another 90, and then they're fully saturated. So that's what's happening with those sat bands. Remember, you can put those sat bands inside the field of view or outside. So this is just a quick summary of black blood imaging. Due to our time of flight effects, due to slice thickness, TE, and flow velocity, the blood will appear dark. Our saturation pulses will help enhance this effect to make the blood appear even darker. So if you have an increase in signal coming from a vessel, this is an indication of slow flow, clot, or an occlusion. So just like the image we had before, where we had a thrombosis within that pulmonary vein, that is indicative of a slow blood flow or a clot, which is a thrombosis. So if you get asked on a test, if you look out, everybody starts writing. What would the clot appear as on black blood imaging? Would it appear bright or dark? Would it appear hyper-intense or hypo-intense? Hyper-intense. All right. And then we describe bright blood imaging. So this is our gradient echo pulse sequences, which is flow sensitive. So we're enhancing signal from flowing blood. So this is our hemodynamic. So we use really fast pulse sequences that don't have a 180-degree refocusing pulse. We use gradient moment nulling to correct for intravoxel dephasing. And sometimes we just inject contrast to also further increase our signal from that vessel. Our contrast is gadolinium based, and due to its property, it can either be linear, meaning it's a molecule that is almost, the gadolinium isn't completely encapsulated by its chelate, or it could be macrocyclic, which means it's completely encapsulated. The macrocyclic agents are more stable, and there's big controversy about gadolinium deposition going on, and those usually are more stable and result in less tissue deposition of gadolinium. But what the parameters of gadolinium, it usually has 7 unpaired electrons that interact with the tissue lattice. And remember, tissue lattice is associated with T1 versus T2, which is spin-spin. T1, so it reduces our T1 relaxation rates, so it appears brighter on T1 weighted images. That's why usually after contrast, we mostly scan T1 weighted images. So here's just an example of our bright blood imaging. We're using a gradient echo where blood flow is bright. In our gradient echo, it's usually a T1, right? We already talked about that. A T1, what's a T1 gradient echo? Is it a coherent, incoherent, steady state prepossession? Which one was it? Do you remember?
What was the question?
Which type of gradient echo usually creates a T1 weighted image? It's back when we were talking about gradient echo pulse sequence. It is commonly an incoherent, which is also called a spoil gradient echo pulse sequence. So you're spoiling away that residual transverse magnetization. It creates a more T1 weighted image. Spoiling away residual transverse magnetization gives you a more T1 weighted image. But you can have a T2 gradient echo, which is the coherent gradient echo. So, but if it's a post-contrast, usually it's an incoherent gradient. All right, here we have bright blood, and you can see all the different chambers of the heart. What are those muscles that are in the ventricles? What are those muscles?
The chordae tendae?
Those are, yeah, they attach to the muscles, but the capillaries.
Oh.
Yeah. Chordae tendae, the tendons are attached to the muscles. So we're getting high signal from blood flow because we only have one RF pulse, and then the gradients rephase it. We don't have that 180-degree refocusing pulse, which limits our imaging of flowing blood. What's our flip angle within gradient echo? Greater or less than 90. It's a lot shorter. It's like 15 to 20. So just a quick recap of bright blood imaging. So due to our time of flight effects, the blood flow within the vessel is going to appear bright. Our gradient moment nulling or refocusing, also sometimes if you see an R there, will increase this effect. So by reducing our intrafoxal dephasing. So in this case, if you have a decrease in signal within this carotid artery here, that will indicate slow blood flow, a clot, or occlusion. So if you see a bright blood flow sequence, but then you see a little dot of black, that can indicate these things. So hypointense on a gradient echo means blood clot, or other various pathologies. All right. What's that? So a hypointensity within a gradient echo pulse sequence usually means a blood clot or occlusion. So remember how I say gradient echoes are associated with MRA imaging because it's bright blood flow usually, which is angiography. So these are the 4 types of MRA techniques. We have digital subtraction. We have our time of flight, could be either 2D or 3D. You have your phase contrast, which is set by our velocity encoding gradient. And then you have contrast enhanced MRA, where we're just injecting our contrast and watching what happens. Which one of these do you think we would use for the chest or abdomen where we have issues with respiratory artifacts? Which one of these? Which one's the fastest, you think? Contrast enhanced, right? These usually are seconds. Usually we're acquiring a slice per second. It's the fastest one. We're almost watching it in real time, right? We have that bolus tracking where we turn it on, and we're almost watching, boom, boom, boom. We're waiting for that contrast to get to that abdominal artery. Boom, we start our pulse sequence. That's contrast enhanced. Phase contrast, it could take 3-4 minutes. Time of flight. We know when we do that MRA of the head, it takes a little while. It takes like 5 minutes, right? You cover from the corpus callosum all the way down to the foramen magnum because that's where your circle of Willis is. You put a set band above because you want to null any venous blood flow coming back down. It usually takes 5 minutes. It's a longer sequence. In digital subtraction, it's really just our contrast enhanced subtracted from our normal pre-contrast images. So it's not really a timing thing. It's just a post-processing thing. This is just a visual representation of the difference in these different types of MRA sequences. Here on the left, we have a digital subtraction. So we have the flow that has a change in phase is going to be bright. And then our stationary tissue is usually subtracted out. Sometimes it subtracts out better, but usually really short T1 tissues that have a short T1 recovery also sometimes appear bright within the background. So it's not always the best way to get the stationary tissues out of the way. So sometimes with these digital subtractions, you also have to omit, meaning you have to cut out all the stationary tissues so that you see the vessels even better. B here we have a time of flight. And then after the time of flight, they did nip around the area. Where do you think we're imaging right here? When do we get this divide in the artery?
The iliac.
Yeah. So we get the abdominal aorta that divides into the iliac arteries. And then third image here, see, this is a 3D contrast enhanced. So this is the contrast enhanced. And you can see the size of the thrombosis or the blood clot here or stenosis, whatever this pathology might be, is different size depending on the pulse sequence that you use. So the best indicator of the true size of that pathology would be our contrast enhanced because it is our fastest pulse sequence. And it's a 3D, meaning it's going to give us good resolution. All right, so for our first MRA technique is our digital subtraction. So basically, we have two sequences that have the exact same parameters. So that's why when those MRI techs, they freak out if you change any of those parameters of the pre and the post, right? They're like, don't mess with any of the parameters because if you mess with any parameters, it won't automatically subtract. Because you might have two different field of views, which means your boxers are going to be a different size. Your TRs might be a little different. So don't mess with how it's set up post-contrast once you set it up pre-contrast. It won't subtract appropriately if you do that. So what it does is takes the post-GAD images and subtracts from the pre-GAD images. And the only thing that's changed between those two images is the contrast flowing within that vessel. So now that we have really high signal coming from that vessel, everything else gets subtracted out, which is our stationary tissue. So our vessel becomes brighter because of subtraction. Okay? Our next MRA technique is time of flight. And here we're using the incoherent gradient echo, which is also called a what?
Spoil.
Spoil. I guarantee you the registry will use those interchangeably throughout the test. So make sure you know that incoherent means spoiled, which means what type of wave?
T1.
T1. So with our time of flight, we're using an incoherent, spoiled T1 gradient echo with our gradient moment nulling. So we get bright signal within that vessel. We get dark CSF. We get bright fat. But usually post-contrasts are also fat-sided, right? Most of our post-contrasts are fat-sided.
What did the R stand for in GMR? Rephasing?
Rephasing. So it could be GMN, gradient moment nulling, or GMR, rephasing, gradient moment rephasing. So with our time of flight, we keep our TR very low, so we don't get any recovery from those stationary spins. But we want to make sure that our TR is not so low that we actually start to saturate our flowing spins, which are going a little bit faster. And they're changing phase a little bit more than our stationary spins. So here are some parameters for our 2D time of flight. So our TR between 40 and 50 milliseconds. We keep our TE to a minimum. And then you can see here our flip angle is about a 45 to 60 degree flip angle. What's a TR for a T1 weighted spin echo? What's usually our range for a spin echo? 300 to 700. So just see how, look how much faster a gradient echoes versus a spin. Remember, we're trying to image flowing blood, so we have to image very fast. Keeping a minimum TE also helps to reduce for these artifacts, the intravoxel dephasing, phase ghosting, and susceptibility artifacts. If you keep your TE low, we don't allow those spins to dephase completely. Because our TE, the longer our TE, the more, with that T2 curve, the more our signal decreases. Remember, we want signal from flowing blood. So this is optimal for slower velocity. So highlight this. Optimal for slower velocity. So our venous blood flow, or our blood flow that's a little bit slower than our circle of Willis, which is our carotid arteries. So our carotids, peripheral vasculature, like in our arms and our legs, and venous blood flow, like in our IVC. A little bit slower than our circle of Willis. This is used for a large area of coverage. So think the size of your carotids, basically from your EAM all the way down to your aortic arch, which is about right here. So this area is a lot larger than our circle of Willis, which is only about that big. We can use it for larger areas because we're not as concerned with the saturation issues, because it's a 2D pulse sequence versus a 3D, because we go through one slice at a time. This is just a reminder of stationary tissues versus fresh. So that's just a slide that's repeated from our flow. So remember, stationary tissue, saturated, beaten down, flowing blood, fresh, higher signal. All right, now let's compare that to our 3D time of flight. Once again, 3D, we're really concerned with our circle of Willis, which has faster blood flow and a lot of twists and turns. So we get really high signal from a 3D because we're exciting the whole slab versus just a particular slice. So that whole area of field of view is usually excited at once. And when you excite more spins, you get more signal. And you get higher resolution because your voxels can be as thin, and your slice thickness can be as thin as 1 millimeter compared to most of your 2D acquisitions. The thinnest you can get a 2D acquisition is usually about 3 millimeters. Okay? So we do have two good things that happen with this 3D time of flight, but then we get some negative aspects. We get two major trade-offs. So the spins, these flowing blood spins, spend a lot longer time going through a slab versus just one slice, which results in more saturation. More saturation means less signal from blood flow. So even fast-moving blood flow will begin to saturate at some point. So they have created a couple remedies for these 3D time of flight saturation issues. The first one is what we call MOTSA. We'll go over what that stands for. This helps maintain signal from flowing blood in a 3D slab because it creates multiple 3D slabs as you go up. Or we could utilize a ramped RF pulse, meaning our flip angle changes as we go through further and further through the stack of tissue. So usually with a ramped RF pulse, we start with a very small flip angle because we already have a very large longitudinal magnetization, so that will create a little bit more signal. But then as our longitudinal magnetization decreases as we go through the tissue, we use a larger flip angle to get more signal from that particular vector. So this ramped RF pulse means we start with a small flip angle and gradually increase our flip angle as we go through. So this is sometimes also referred to as, let's see, RF tone, if you see it on your scanner. A ramped flip angle is also called RF tone. And that tone stands for, let's create another little thing here. T, tilt, optimization, non-saturation, excitation. RF tone, and tone stands for tilt, optimization, non-saturation, excitation. That's enough. So the tilt is basically dealing with flip angle. Flip angle increases as flowing blood travels through slab. So RF tone also means ramped RF. Ramped RF, because you're ramping it up. Right. I think I have written down. So here is an example of the MOTSA, which means multiple overlapping thin section angiography. So these are multiple RF, a 3D slabs. So if it looked like, it really kind of looks like this. Our slab, there's one slab, here's another, here's another. So this is good because it reduces the amount of saturation so you can cover a larger area. So once again, here is the carotids, which we usually cover. It's the carotids and the circulolus, which we usually cover with a 2D because we can cover a larger volume with a 2D time of flight. But if you stack your 3Ds on top of each other, that helps that saturation issue. But the only drawback to this MOTSA is if the patient moves in between acquisition of this slab and this slab, it creates this artifact right here. It's what we call Venetian blind artifact. And you guys have Venetian blinds in your house, right? Look just like these. Doesn't that look like that? It's a Venetian blind artifact. And this is where the patient has moved, or we don't have enough space between the slabs. So sometimes we'll have almost a more saturated spin at the end of this slab, and then it starts new here, so it creates that Venetian blind artifact, where you get a little bit more saturation, and then at the beginning of this slab, we get a little bit more fresh spins, creates that Venetian blind artifact, where the patient moves. So to recap, our 2D versus 3D. Our 2D time of flight is usually used to cover a larger area. And with time of flight, do we need contrast?
No.
You don't need contrast with the time of flight. You can increase our signal within that vessel by injecting contrast, and sometimes they do, but you don't necessarily need contrast with time of flight. So that's why this type of imaging, MRA imaging, is really useful when a patient has an allergy to gadolinium. Just contraindicated for gadolinium altogether. Maybe they have some kind of renal insufficiency where their GFR is pretty low and they can't get contrast because they can't filter it out. Maybe they're a dialysis patient. Maybe they're a patient that gets repetitive scans because they have MS. They need to not have gadolinium so often. A good way to visualize the vessels would be time of flight. 2D time of flight is good for larger areas, slower blood flow, like our carotids or our venous structures, and then our 3D time of flight is better for a smaller field of view, and it's really good for imaging very fast, a lot of twists and turns within that particular vessel, like our circle was. Okay. So let's take a quick break before we go on to, let's wrap up this time of flight. I know, we'll take a break right there, and then we'll continue on. Pause the... Alright, so 2D time of flight is good for larger areas like the carotids and slower blood flow, and then 3D is for smaller areas like the circle flows. Sometimes if the patient can't get contrast, what they do is they 2D time of flight of their carotids, and then sometimes they just do a 3D right at the bifurcation of those carotids when it goes from the internal to external carotids to help visualize that area, because that's a lot of times that's where the stenosis or the pathology is going to be at. So they'll do a 3D through that particular area. All right, time of flight with gadolinium enhancement. So most of the time you don't need gadolinium contrast when we're doing these time of flights, but if it does ask for it, if the ordering physician says a time of flight with and without contrast, you're going to get higher signal with those vessels because we're going to shorten our T1 times. So let's go over our T1 relaxation curve one more time here. So our y-axis and then our x. X-axis here. So our y-axis is our what? If we had to label this, what is it going to be?
You still get like coronal? D sub 0.
D sub 0 could be our magnetization of our longitudinal axis, which is M sub Z. And then our transverse plane is going to be M sub X, Y. Or sometimes it's labeled as B sub 1. Okay? So this is T1 relaxation. What are some other names of T1? Not T1 decay, T1 recovery, because our signal is going to be recovering on this axis. And also sometimes referred to as our spin lattice. So this was from chapter 2. And then our T2 relaxation is also called T2 decay or spin. All right, so normally, let's use the pencil here. Let's say our pathology is going to be blue. So we have some cancer, some tumor. It recovers like this. up to full recovery, which is 100%. And remember, our tissue is considered fully recovered at what percent? 63. Okay. And then we're usually governed with T1 by TR. T2 is TE. All right, so what happens with this gadolinium once it's injected into our bloodstream? Due to its 7 unpaired electrons, and remember, we are going to be basically coming into contact with our tissue lattice. And our tissue lattice is all those hydrogen spins within all the different tissues. So remember, the hydrogen spins are usually denoted as H positive, because remember, it has 1 proton, but 0 what? What makes it spin? It has 1 proton, but 0 what? What's in a nucleus? Neutrons. 1 proton, 0 neutrons, it gives it that net spin. It starts spinning on its axis. It does have 1 electron. So if you have all of these gadolinium that have that 7 negative aspect, and then you have all these H positives, it's going to react with the tissue lattice a little bit more. And if it reacts with the tissue lattice, it's going to recover a lot faster. So this tumor here that we couldn't see on a T1 pre-contrast, so with a T1 pre-contrast, the contrast wasn't that much different from normal brain tissue, so it was hard to see. It was a gray, but it wasn't that bright. So what happens here is it shifts this recovery curve to the left. And now the tumor recovers a lot faster due to those properties with gadolinium in it. And this is our tumor plus our gadolinium. So if we recover a lot faster, we're going to have higher signal for the next RF pulse to flip it into the transverse plane. So we're going to get brighter signal. So this curve increases our signal intensity, and you see it as that bright signal on our post-contrast images. So that's what's happening when we have gadolinium enhancement. We'll cover that more when we go into contrast next year. So this is just saying gadolinium further increases their signal within the vessel. So here are just your 2D and 3D advantages. 2D, larger area, good for slow flow. 3D, very high resolution. It's great for visualizing our smaller vessels, like in our circle of Willis. Disadvantages, 2D, we get saturation of in-plane flow. In-plane, remember, most of the time we're imaging flow that's perpendicular. In-plane means that our flow is parallel to the slice. So on a 2D, we really can't image in-plane flow. So we have our carotids coming up, and we set up our slices 90 degrees from that. But if our carotids, for some reason, went completely at a right angle, we would get a signal void from that part of the carotid. But our 3D is better equipped at visualizing those twists and turns. You do get a little bit of saturation of the inflow, but it's not as bad as our 2D. So we're still able to better visualize in plane. Right? Sometimes when we do these circle of Willis time of flights, there's a little bit of a disadvantage because some tissues, like the retroorbital fat, remember, fat has a very quick recovery curve, right? And I drew that recovery curve a couple minutes ago. This retroorbital fat sometimes has a curve that matches up with our vessels. So if our retroorbital fat is very quick to recover, it's also going to produce signal. So we want this retroorbital fat to be dark because it's a stationary tissue compared to our flowing blood that is fresh and coming into our slab new. So to further saturate out this retroorbital fat or these structures that have a very short T1 recovery time, what we do is use our magnetic transfer coherence, and that further suppresses those tissues. So to compensate for that retroorbital fat, we use magnetization transfer coherence. So it suppresses signal from that retroorbital fat and white and gray matter a little bit better. So all those structures within the time of flight, stationary tissues get saturated out. We could also use a TE where fat and water are out of phase. So 2.1 TE on a gradient echo. We'll get no signal from those particular volatiles that have fat and water in them. That's another way to remedy that retroorbital fat. If you increase your field strength, you get better visualization of those smaller vessels within the circle of Willis. So here is a 1.5 Tesla. You can see the major, anterior communicating, middle cerebral artery, posterior communicating, posterior arteries. But look at how much better you can visualize even the smaller branches of the circle of Willis with your time of flight, with your 3 Tesla. And that's just because if you start off with more signal, you can basically get more signal from those vessels. All right, so with our time of flight, most of the time we usually have to MIP them, right? So the tech that you're working with is go, oh great, you did your time of flight sequence, now you have to MIP your circle of Willis. You have to MIP the anterior from the posterior, then you have to spin, and you have to nod or tumble those particular arteries. So what is MIP? MIP stands for maximum pixel intensity. So this is mostly the computer doing all the work because it's post-processing. So projection rays pass through the data volume to create a 2D image. So then heavy mathematics that you guys don't need to know are applied to the data set to determine how bright each pixel should be in the image. So that's where you get the name maximum pixel intensity. This is repeated at all different angles to give a 3D representation. That's why when you put it in that post-processing on the Siemens, you can flip and twist and turn that MIP image any way you want so that you can cut out those vessels appropriately. Sometimes complex flow patterns can be misrepresented as a stenosis or occlusion. So to make sure that the radiologist always checks the source image along with the MIP images, because sometimes as a tech you accidentally clip the vessel. You don't want to do that, but the radiologist should know that, oh, that was by accident that you clipped it, it's not a stenosis, right? So what they do is they look at the source image, which is our time of flight image that is collapsed down, and you can actually flip through all those slices to see if there's actually a narrowing of those vessels that corresponds with our MIP image. So I have a video here that really goes through a radiologist looking at vessels and how he goes through a MIP image of the circle of Willis. And this is a CT, but it's the same concept because CT does MIPing also. So let's watch this real quick. Listen to what he said.
We're going to talk about MIPs and how they are useful for the interpretation of angiographs. So what is MIP? MIP is the maximum intensity projection. And essentially consists of taking information from a set of source images, essentially something very similar to very fine texture, in this case 0.6 millimeter thick slices, and essentially putting together information across many of the slices in a paper regimen, collapsing it down in a fashion that I'll show diagrammatically in this moment, so that we see much more information in a given slice. It also provides nice, beautiful images of the arteries still right against the brain, showing greater extent of the arterial system with the contrast lighting up those blood vessels. Here we see that the source images, you can see as we scroll up and down, we have very thin text, and so we have to go up and down to follow each of these individual vessels. It's certainly possible to do, but it requires a little bit of work on our part to trace out these vessels, and yet on thick net reconstruction here in the axial plane of the same patient, we see the entire extent, much of the extent of the middle cerebral artery, and it's very easy to see this large artery occlusion on the left side, which of course you can see on the source images, and you need to confirm the source images, and using thick net reconstructions, it makes it that much easier to see it on the first pass evaluation. So that's one of the major uses. In the acute stroke setting, you can very quickly ascertain, yes, here indeed is on this thick net reconstruction, a large artery occlusion. Another useful thing about this is you use it in the plane. Here we have our axial thickness, and this is the coronal thickness, so we can get another view of this, taking that source information and reconstructing it in the coronal plane. And so here we have a coronal view of the same thing, that large artery occlusion on the left side. Okay, so how does this work? What is the computer doing with the information from the original cascade angiogram to generate these thick net reconstructions? We imagine that the brain is this stylized cube consisting of individual voxels or three-dimensional pixels. Then we have an x-axis and a y-axis, and we imagine each of our thin sections is here. As we scroll up and down in our source images, we'd be looking at different thin slabs here running up and down. This is our z-axis, and as we scroll from sort of top of the head to the bottom of the head. And inside of this stylized cube of brain, we have blue pixels, let's say that represents brain, and then we have brighter pixels representing the contrast of calcified arteries here inside of that three-dimensional space. And if we were to collapse down the entire brain, you would see this overlay projection of all of the arteries if we follow a very simple rule, which is if we look across a z-axis series of voxels at a given xy location, and we ask what is the maximum intensity of any voxel in that stack. And whatever that is, we apply that here in this two-dimensional slice representation. And so in this case, it's not very bright. It's the background intensity of the brain, and so it's a darker pixel in our 2D representation. On this slice here, on this z-axis, at this xy position, we have two voxels that have bright information. And so taking the average brightness, usually one of them will come out ahead and be the maximum intensity, and presumably that's this voxel right here, and that gets represented in our two-dimensional slice. And we follow that rule of each of these thin stacks, z-axis stacks of voxels. As we do that, if we project down the entire brain, we take that from top to bottom, we're going to have a projection of all of these arteries, but it's going to lose that spatial relationship in the z-axis, and so everything's going to be overlaid. We won't know, is this a separate artery from this, or is this all one big fat artery, or we don't know. So to overcome that problem, we simply take smaller wedges in the entire brain, but not so small that we take away the advantages of the thick-net projection. So instead of projecting across the entire brain in the z-axis, we choose slabs that are not the entire extent of the z-axis, but in this case, let's say 15 millimeter slabs. Then that means that this is our new area of volume, and then that is what we're projecting along into our 2D representation. Following that same maximum intensity rule, looking through each stack of voxels, where this one is dark, this one has some bright content, so it's going to end up bright, and so forth. And depending on what thickness we set, we're going to overcome that problem of too much superposition of these contrast calcified arteries. And at some point, there will be an optimum thickness. You can choose to make it, in this case, 15 millimeters, you can make it 5 millimeters. In this case, because the arteries are running straight up and down, this achieves the optimum projection where you can see individual arteries silhouetted against cranial or subarachnoid space. And as we scroll this slab up and down, effectively creating a stack of 2 images, it will produce our optimum slab thickness. But that thickness depends on exactly how you set the scan and exactly what you're trying to look at. And sometimes these will be 5 millimeter thick slabs, sometimes it will be 10 millimeter thick slabs, depending on the protocol used on the scan. When you're looking at a thickness reconstruction and when you're playing, you can see the thickness, the slice thickness provided in the icon overlay, typically in the bottom left hand here, and it was presented with 10 millimeter slice thickness here. It doesn't tell you that that's a slice thickness, but you can see as you're scrolling, the number doesn't change. The number above it does, and that's the actual current slice center position. And what we can see is that we're not, in this case, moving this 10 millimeter thick slab by 10 millimeters each time. Instead, we're moving the center of it smaller, and that smaller can vary according to the protocol that's used. In this case, if you look, it says 180.7 one position, and we move it small, one section away on a stack of slices. And we go from 180.7 down to 178.7-ish. So it's moving by approximately 2 millimeters each time, despite the fact that the slice thickness is much greater than that, it's 10 millimeters. So that's how you can tell basic information about the reconstruction that you're looking at on a thick method. A special thanks to Fishman and colleagues.
Alright, so I hope that clarified a little bit of what a maximum intensity pixel, what's going on there. Alright, so our next MRA technique is our contrast enhanced. And remember, this is best imaging option for our chest, neck, and abdomen, where we're going to get that respiratory artifact or that swallowing artifact from our neck. Time of flight and phase encoding, phase contrast MRA are not the best because it does not compensate for that motion artifact, and we get potential signal loss in vascular structures due to in-plane, remember, the parallel blood flow to our slice. So contrast enhanced, great for these areas because we're imaging very fast. So we're using a 3D T1 gradient echo, so that's going to be an incoherent, spoiled gradient echo. We're going to get a pre and a post. Usually our post, we're going to inject our contrast using a bolus injection. A bolus injection is just a lot of contrast at a very fast rate. And this is usually done for dynamic imaging. Dynamic imaging means that we're going to be timing our contrast to visualize the arterial blood flow, the venous or intermediate blood flow, and our delayed vascular imaging. So that helps the radiologist diagnose certain cancers. So it's really important that we take in all these considerations: our protocol, our injection method, the type of contrast and the dosage, and our scan timing. Our scan timing should be very rapid to image while that contrast is in the artery, while it's in the vein, while it's in the delayed phase. We could also use subtraction to better visualize those contrast-enhanced areas. So our Siemens system automatically does that. The GE, the older GE system, usually you have to do that manually, post-processing. These are 3D sequences, so we have very high spatial resolution, so usually voxels that are less than 1 millimeter. We have high temporal resolution. Temporal resolution means we're imaging very rapidly. So usually high temporal resolution is like 1 slice per second. We're able to acquire 1 slice per second. So these are usually very fast 3D T1 gradient echo breath hold exams. So they're only a couple seconds, so you just have the patient hold their breath and then start the pulse sequence. So as you inject, usually you start to click through all those okays, but then there's that one where you have to make sure they hold their breath while you're imaging the arterial phase of the abdomen. Our injector, usually we have to do our power injector for our dynamic imaging. So anytime you're doing abdomens, where you have to see the arterial, venous, and delayed imaging, you're using power injector, right? Because you're not able to get in there and inject as fast as the power injector and as consistently as the power injector. So we're hooking them up to our power injector. You're setting your rate. What is a normal rate for an abdomen? What do you think? How many cc's per second? What do you guys usually set it at? And it's same for the brain if you happen to do a brain too.
3.
Like 3 to 5, 4 or 5, normal abdomen. But then if you have a perfusion study, have you guys done a perfusion brain? Anybody here done a perfusion brain? We'll talk about perfusion and functional MRI, but that's where you're injecting a lot more contrast at a lot faster rate. And that's usually at 2 cc's per second. So depending on what type of scan or exam you're doing, that will determine your injection rate. Our contrast dosage, this is the same as when we covered MR safety. So 0.1 millimole per kilogram of body weight. You guys usually have your charts, your conversion charts. If you had a 150-pound patient, what's the usual conversion? How many cc's of contrast?
15.
About 15. So it's about 1 cc per 10 pounds of patient. And then our scan time. You're usually using that fluoro triggering or that bolus tracking with these type of images. So you have that quick live projection where you're getting 1 slice per second. You're watching the contrast go through the heart and then go up the aortic arch and then start to come down. Boom, we start our sequence, right? That's what the scan timing is doing. So this is the beautiful images that we get, right? We have very high signal within the vessel, and we get good background suppression. So the only thing that's changed is the phase values of the flowing, moving spins. So this gives us a really good idea of how morphology and hemodynamics with contrast-enhanced imaging. So we can really see the size of the vessel, if there's any areas that are stenosed, and we can see if the blood flow is flowing adequately. So here's the abdominal aorta. Here's we got the carotids. Here is the candy cane projection of the thoracic aorta going out to your subclavian arteries. All right. And then last but not least is our phase contrast MRA. So our phase contrast relies on velocity-induced phase shift. So remember, our blood flow is flowing at different velocities, right? Our aorta is the fastest. Then you start to get out towards the periphery, our blood flow slows down. Our venous blood flow coming back to the heart is pretty slow also. So with the different velocities, we get different phase shifts. So faster blood flow basically interacts with more and more of the gradients. So as we go faster blood flow, our phase shift changes a lot more. So think of our phase shift as a clock. Faster blood flow, so we start at 12 o'clock, it's already at 6 o'clock as it moves throughout the patient. Slower blood flow, we start at 12 o'clock, and it's only moved about 3 o'clock. So that's what it means by these velocity-induced phase shifts. So our PC-MRA provides information not only about vascular anatomy, but it gives us information about flow velocity, multi-directional blood flow, and then this is just a duplicate, and then just directional blood flow. So multi-directional blood flow is really all we need. So how does it do this? It uses a gradient echo pulse sequence with a small flip angle and additional bipolar gradients. These VENC, velocity encoding bipolar gradients. So if you see VENC on the test, and your options are all those MR pulse sequences, make sure to choose PCMRA. Always, always, always associate this little acronym with PCMRA. So if there's one thing you remember from this PowerPoint and this lecture today, always associate. Because if you guys don't exactly memorize the concept, association is your next best thing, okay? Because when you get to the registry, all this stuff is jumbled in your head. You're not going to exactly remember what does VENC stand for. What does it do again? But I know it. I associate VENC with phase contrast MRI. That's just how the registry goes. X-ray and MRI. You're not going to be able to retain everything. So your next best thing is association. But this VENC velocity encoding gradients cause a greater phase shift in moving spins than stationary spins. Remember, the stationary spins aren't going anywhere. So those are like your background tissue, like your brain tissue, your liver tissue, things like that that are just going to be locked in their place within a particular slice. Flowing blood is moving along those gradients. So if you turn those gradients on stronger, you'll get a greater phase shift. So I said that PCMRA, you can visualize different blood flowing velocities. So how it does it is by selecting a velocity encoding gradient that is set up to maximize signal from different blood flows. So this VENC has a unit, which is centimeters per second. And we can set our VENC to visualize venous blood flow or arterial blood flow. So our VENC, you can see, has gone up because arterial blood flow is flowing at a faster rate. So basically, it produces these phase shifts within that arterial blood flow at 80 centimeters per second. And then everything else gets saturated out because it's not at that particular velocity. So it gives us really good background suppression, the best background suppression out of all of the techniques. So you get really good flowing blood signal, but then all your stationary tissue is really suppressed, which is really good for high contrast imaging structure. And another thing we said that it can visualize multi-directional blood flow, and how it does that is basically applying those gradients in all three directions. So these bipolar gradients can be applied in the X, Y, and Z axis, which will make it more sensitive to flow. So the benefit will be able to evaluate multi-directional blood flow. So that's why it's really good for that superior sagittal sinus, that kind of, you got your transverse sinus, and it leads into your superior sagittal sinus and goes down your jugulars. You can really visualize those venous structures within the head very well with the PCMRA. Anytime you add more gradients, it will increase our image time. So as you go from a 2D PC to a 3D PC, it's just going to increase our imaging time. So here we have our circle of Willis, and then sometimes this is what it looks like with these phase contrast MRA images, where you can tell the direction of the blood flow by whether the vessel is bright versus dark. So here we set a gradient going right to left, and so we knew that if the VENC, if the blood vessel was white, the slice is in the same direction of the blood flow. But if it's dark, our slice is in the opposite direction of the blood flow. So it appears dark. So that's how we're able to visualize multi-directional blood flow. So here's just a breakdown between 2D and 3D PC. So 2D is a little bit faster, which are acceptable imaging times, 1 to 3 minutes. So even though it gives us really good background suppression, if we choose a 3D PC, sometimes the patient moves, and that can degrade our image quality. Our 3D gives us very high resolution, high signal, and it's better at identifying those arteriovenous malformations where you have almost an outpatching of where those two vessels meet, and intracranial aneurysms. So this is a great image of a 3D PC of our superior sagittal sinus. So just a quick review of advantages and disadvantages. Our advantages, it's sensitive to a variety of velocities. And then always remember, velocity is always with your acronym, B and C. Can evaluate multi-directional blood flow, because if you have a vessel bright and then another vessel dark, that gives you a clue of which way the blood's flowing. It reduces our intravoxel dephrasing. It really suppresses that background tissue because you're selecting a particular velocity of blood flow and then everything else gets suppressed. And it can evaluate blood flow and direction. So that goes along with this. Disadvantages, it does have a longer imaging time, especially in 3D. And sometimes it's a little bit more sensitive to turbulence. So if you have turbulent blood flow, it can create a little bit of a signal for it. So what is really happening with those PC bipolar gradients, let's just take a gradient echo. So if you had blood flow going on the frequency encoding axis, you could just create those bipolar gradients on this axis. So it looks something like this. But if you have blood flow going in all 3 directions, you do that on each of these axes so that you can visualize blood flow in any direction. So these gradients, these bipolar gradients, create a larger phase shift so that you can visualize flowing blood better than stationary tissue. Okay? All right, so that wraps up our discussion today on vasculature. You guys have any questions today? All right, so quick reminder, you guys have the exam on lower extremity. So go to your echo, go to your review, watch that. You have a quiz on vascular. Okay? This quiz is not like the test where you have sample test questions. You're just going to have to study the PowerPoints of cardiac and this. Go over those math problems that we went over last class on available imaging time and the effective TR. So make sure you know how to calculate for the effective TR and available imaging time. Know what the waveform is. Things like that, retrospective versus prospective gating, and then know all your vascular techniques. Okay. Next class we'll review, and then we'll have the exam on vascular and cardiac. The next one.
Oh.
So it's just a quiz this Sunday. It's a quiz this Sunday, but remember you have a test on lower extremity to go along with it, and then you'll have a lot of review before the exam. Okay. But the quiz will be on campus.